going to touch here on conjunctivitis. This is something that you're going to commonly see, especially if you're working with pediatric population or in an adult population, particularly during this time of the year that I'm recording this now, which is December. The months between November and April are the most common months that people show with conjunctivitis. So we're going to go into the anatomy very briefly. We'll talk about the clinical picture, how these patients come in, then some of the causative agents, some of the precipitating causes that cause the development of conjunctivitis. We'll also go into the treatment and then the differential diagnosis, which is going to be important, not just for determining whether or not this is conjunctivitis, but to determine if it's not, because there are some things that if you miss can have really devastating consequences on the patient. And then finally, some clinical strategies that I think are kind of useful for real-life applications. So the conjunctiva is a squamous epithelium lined also with goblet cells that produce both a somewhat lubricating and protective layer over the inner eyelids and the exposed surface of the eye. And there are different names for the conjunctiva based on where it's at, but the one I want to draw your attention to is the palpebral conjunctiva, and that's the conjunctiva that's reflected over the inner eyelid. All right, so conjunctivitis is an inflammation of the conjunctiva due to an infectious or an allergic response, and this is the most common eye disease that is seen in medicine. Typically, the patient is going to come in complaining about eye discomfort and itchiness and a red eye or a pink eye. This is also called pink eye, especially when it happens to little kids. So that red eye is diffuse conjunctival injection, and that's occurring because there is inflammation, and whenever there's inflammation, you're going to get increased flow to the vessels, and so you'll see those vessels that typically are much smaller and less prominent. So what's important, though, while there is red eye and there is eye discomfort, itchiness, what there isn't, and that's going to help you pin down the diagnosis of conjunctivitis, is that there isn't visual changes, and it's not severe pain. It's discomfort or mild pain. It's not severe pain. There also may be present in conjunctivitis discharge, and usually there is discharge, and if it can be watery or it can be purulent. That discharge can dry up, and when it dries up, especially after the person has had their eyes closed for a long time, like after sleeping, that discharge dries up and becomes sticky, and the patient will often affirm, if you ask them, that when they wake up, their lids are sticking together in the morning. Conjunctivitis can be bilateral or unilateral. Usually when it's the allergic conjunctivitis, it tends to be more bilateral. When it's infectious, it tends to be more unilateral, but that doesn't have to be the case. And like I mentioned earlier, it's more prevalent in those winter and spring months, November through April. Risk factors for conjunctivitis include trichiasis, chronic dry eyes, Sjogren's syndrome, which is an autoimmune chronic dry eyes, and chronic blepharitis. Some of the causative agents. So we're talking here bacterial, but not chlamydial or gonococcal. So the most common agents of bacterial conjunctivitis are staph and strep. And so in these patients, there's usually a noticeably purulent discharge. A lot of times there's often preauricular lymphadenopathy, but it's really, really, really important that when a patient has purulent discharge of the eyes, which usually means bacterial conjunctivitis, as long as there's no eye pain and there's no change in visual acuity. But very, very important to get a sexual history, because if they have a sexual history, high-risk sexual history, or they have recently had urethritis, or they have urethritis or vaginitis, then the chance of this being a gonococcal gonococcal conjunctivitis goes up, and that's going to indicate a different treatment. Very important if there is conjunctivitis with a purulent discharge that you get the sexual history. So chlamydial or gonococcal conjunctivitis is possible in two particular populations. So sexually active patients, and that can be really anywhere from, you should never make assumptions, it can be anywhere from a 12 or 13-year-old. Um, I've seen as young that's as far as I've seen. I suppose it could be younger theoretically, especially if there's abuse, but that's another topic. Sexually active patients or newborns of infected mothers. So in those cases, the newborn was coming through the birth tract and they contracted the chlamydia or the gonorrhea through the birth canal. So when you're dealing with an adult patient that can talk to you, an older child or adult patient, very important to get the sexual history. When it's a little baby, then you need to get the history on the mother. Has the mother had any past urethritis recently, vaginitis? Is there a positive culture? Usually they do cultures to check in part of the prenatal tests, and also get a sexual history. Okay, so viral conjunctivitis is probably the most common cause of conjunctivitis overall, and the most common agent of viral conjunctivitis is adenovirus. And adenovirus also is a common cause of respiratory tract infections. And so this is highly contagious, and usually when a patient has viral conjunctivitis, if you ask them, usually they will have recently had some kind of a respiratory tract issue, stuffy nose, cough, sore throat, possibly. Usually in patients with viral conjunctivitis, the discharge is watery, but a watery discharge can also be seen with the chlamydial conjunctivitis. And in viral conjunctivitis, they may not even note a discharge. So that's up in the air. But usually viral conjunctivitis will be associated with a more watery discharge. You can also see preauricular lymphadenopathy in these patients as well. But what you won't see in viral conjunctivitis is that purulent discharge. There are some cases of viral conjunctivitis that aren't due to adenovirus, and these are important to keep in mind. So there's one that's caused from varicella zoster virus, and remember that is the chickenpox virus. And usually you will see these in children that get the chickenpox, and they'll have a general vesicular eruption, which is that typical chickenpox rash where you've got vesicles of different ages, and they'll also have fever, malaise, and systemic symptoms that are also present. Herpes simplex conjunctivitis occurs typically in newborns of infected mothers, but also can occur in adults, and this is associated with eyelid vesicular eruptions. So you can see the skin eruptions elsewhere, but usually what you'll note is the vesicular eruption around the eyelids. That's going to be present because usually when there is eruption around the eyelids, then it's going to affect the conjunctiva. And then herpes zoster ophthalmicus is essentially shingles that infects the eye. And it infects the eye because that shingles virus has infected that first division of the trigeminal nerve, which is the ophthalmic nerve, and that will affect the conjunctiva as well as the skin that the ophthalmic division is associated with. And this is associated with that characteristic prodrome. Usually that prodrome before shingles is described as a localized itchiness or pain, and then that's followed by a papular rash and fever. So here's a bacterial conjunctivitis, and what you note here is that purulent discharge. And you see it usually where you're going to see it most is along the margins of the eyelid and on the base of the eyelashes. And then, of course, you see notable injection of the conjunctiva. So here it is in a child. You don't see quite as much of the injection, but you definitely see that purulent drainage there. So in gonococcal conjunctivitis, typically you're going to see this in newborns. And this is typically associated with copious amounts of discharge. And this is a big deal because when a newborn acquires gonococcus, it can lead to other things that are even more problematic than conjunctivitis. So, being aware of the fact that the baby has a sequelae of gonococcal infection is important because you want to prevent other problematic things from happening. So here's viral conjunctivitis. You note the significant injection of the conjunctiva, but what you note is not present is purulent discharge. Here's herpes simplex. So what you note here is that papular rash, these vesicles on the eyelids and the surrounding skin. Here's herpes zoster ophthalmicus. So here's that first branch of the trigeminal nerve. It innervates the skin on the forehead, the scalp, and the bridge of the nose. And you see that characteristic of any kind of shingles, there is an abrupt termination at the midline. Oops, okay. So dry eyes is another cause of conjunctivitis. That's going to just come up in the history. The patient has a history of dry eyes. That's going to put them at risk for viral conjunctivitis or just allergic conjunctivitis, just generalized inflammation of the conjunctiva, can be to chemical causes, smog, etc. Allergic conjunctivitis is another common cause of conjunctivitis as seen in patients. Usually you'll be able to elicit a history of other allergic symptoms, so allergic rhinitis, seasonal allergies, asthma, atopic dermatitis. In allergic conjunctivitis, discharge is typically absent. However, you may confuse tears for discharge. So when you have allergic conjunctivitis, a lot of times you'll have excessive lacrimation, and that can be mistaken as watery discharge. So discharge is typically absent, but if there is wetness around the eyes, don't rule out allergic conjunctivitis. Itchiness is a hallmark feature of allergic conjunctivitis. As a matter of fact, if there's no itchiness, you can almost exclude allergic conjunctivitis. So we call that a sine qua non. And so if there is no itchiness, it's probably not allergic conjunctivitis. Itchiness is prominent with allergic conjunctivitis. Itchiness can be present in any conjunctivitis, but it's prominent in allergic conjunctivitis. And as mentioned earlier, allergic conjunctivitis is much more common, much more frequently occurs bilaterally than infectious conjunctivitis does. So here you see a child with injection in both eyes. No real discharge here. However, you see a little bit of possible tearing here. Here's a cute little baby, and you see the pink eye here. And also in this man too. So what is our differential diagnosis for red eye? So red eye is anything where you have that injected conjunctiva. So first off, conjunctivitis, that should be at the top of your differential because it is the most common. And so in this case, you'll have red eye, you'll have irritation, occasionally discharge, it can be purulent or it can be watery. And then that glued eye, where when there is that discharge, it dries up when the eyes are closed, and then it's hard for it get that glued eye sensation where it's hard to open the eye or you get that resistance. But what there is notably is an absence of change in visual acuity. It doesn't affect the patient's ability to read on the Snellen chart. They don't have blurry vision. And often you see conjunctivitis in the winter and spring months. So during this time of the year that I'm recording this right now, November through April, your suspicion for conjunctivitis should be higher than in the summer months. Okay, so one of our big differentials is acute anterior uveitis. So this is an infection of the uvea. The uvea consists of the iris, the choroid, and the ciliary body. And when there is an infection there, it is not only going to cause severe pain because there's significant innervation in those structures, but that also, particularly the ciliary body and the iris, affects the pupillary response. And so when there is inflammation in the iris and in the ciliary body, you're not able to open your pupil. You're not able to dilate your pupil. So in addition to the red eye and severe pain, typically you will have miosis. And even in dark settings, you won't be able to dilate the pupil. And that's just because of the inflammation. You're unable to open the pupil. They may also have difficulty with fixating. Okay, so in addition to that, of course, they'll have the blurry vision. They typically won't have discharge, and then this pathologic structure called a synechia can be present. All that is it's an adhesion of the iris onto the lens. And that's exactly what it looks like. It looks like a little piece of iris, a little piece of colored iris that is kind of intruding into the pupil. Acute angle closure glaucoma is also associated with red eye and severe pain, as well as blurry vision. But what you will have with acute angle closure glaucoma that distinguishes it from acute anterior uveitis is, in this case, you will have a dilated pupil, not a small pupil. And that pupil can be dilated, or it can be dilated and unresponsive, fixed. And in these patients, in addition, that you can use it to distinguish acute anterior uveitis, is that with glaucoma, the patient, of course, is going to have an elevated intraocular pressure. And there's an instrument you can use to measure the intraocular pressure as long as you use some local anesthetic and get a measurement of your intraocular pressure, and that will help you diagnose glaucoma. And then finally, keratitis presents very similarly to conjunctivitis, except sometimes you can have a modest blurriness, change in visual acuity. But what's going to really help you distinguish keratitis is two things. One, this tends to most commonly affect contact lens wearers. And two, the red eye is seen more prominently around the iris, around the cornea. So those are two things that will help you distinguish the two. But it's very common that keratitis and allergic conjunctivitis are mistaken for one another. So to establish a diagnosis, it's really just clinical. So you do a history and a physical, and make sure, the most important thing is that you ensure there's no change in visual acuity. And for the most part, you can diagnose conjunctivitis that way. However, a slit lamp examination can be useful as well. In patients with severe conjunctivitis, especially if it's purulent, or in patients in whom you have done supportive therapy and it's failed, or their conjunctivitis has not gone away because this tends to be a self-limiting disease, you can do a conjunctival scraping, which will help you determine what pathogen is behind it. And of course, you'll do that with a topical anesthetic, and you'll do a Gram stain and or a Giemsa stain. Giemsa stains are done for chlamydia, and then also culture. But typically, you don't need to do this. It's just diagnosed clinically. So what do we do for treatment? For bacterial conjunctivitis, technically, as long as it's not chlamydia and not gonorrhea, then you don't need to do any treatment other than supportive. The supportive therapy is saline lavage, getting rid of that pus, getting rid of that discharge, and then artificial tears for the symptoms. Now, I say technically because technically non-chlamydial, non-gonococcal bacterial conjunctivitis is self-limited in healthy and immunocompetent patients. However, a lot of doctors like to use antibiotics because it is a bacterial infection, and in most bacterial infections we use antibiotics, so why not use it in conjunctivitis? And so typically what we use are topical fluoroquinolones, particularly ciprofloxacin, but there are a lot of other agents that are available and perfectly fine to use, such as trimethoprim combined with polymyxin B. You can use gentamicin, you can use tobramycin, you can use neomycin. You can also use other fluoroquinolones like ofloxacin, gadifloxacin, and so forth. So there's lots of correct choices, but typically it's the fluoroquinolones that are used. If it is chlamydial conjunctivitis, and that's usually going to be, unlike the other bacterial conjunctivitises, chlamydial conjunctivitis is usually a watery discharge, sticky watery discharge. In the newborn, you'll use erythromycin, liquid, orally, and then in the adult, you'll use azithromycin orally, similar to how you would treat a genital tract infection. With gonorrheal conjunctivitis, in the newborn, you can use ceftriaxone either IV or intramuscularly. In the adult, you'll use a single dose of ceftriaxone IM and then azithromycin PO. And that is done for a similar reason as to how we treat the genital tract infections, because we want to cover both gonorrhea and chlamydia. Okay, so viral conjunctivitis, in this case, it's always supportive of just artificial tears, unless there's a reason to believe that it is one of those other causes, those non-adenovirus causes of viral conjunctivitis. That would be like your herpes, varicella, or HZO. So if you do suspect herpes conjunctivitis, so they got that those vesicles around the eyelids and on the eyelids, then in that case you should just send the patient off for an urgent ophthalmology consult, because they're going to require specialized treatment. This is outside of our realm of expertise. This is going to be done by an ophthalmologist. If it is varicella conjunctivitis, or if it's herpes zoster ophthalmicus, usually you see the varicella in the children and the herpes zoster ophthalmicus in older adults, acyclovir is your treatment of choice. And then another one that I didn't really give a whole lot of time, molluscum contagiosum, that can also cause conjunctivitis. And remember, molluscum contagiosum, that's those little tiny skin nodules that you get. They're skin-colored nodules, and they have that little tiny embellication in the middle of the nodule. If you see those, that can be a cause, so you'll want to remove those, and that can be done in an outpatient setting. Dry eyes, of course, we're just going to be supportive. And then for allergic eye disease, the first approach is going to be either with a topical antihistamine, which you can use levocabastine or imidazine, or a topical NSAID, which you can use ketorolac, but there's lots of other things that you can use for this. I'm just giving you a few examples. And one or the other will be fine. But if it's refractory and the antihistamine or the NSAID is not working, then you can manage it with topical corticosteroid or topical cyclosporine. In patients who have frequent allergic eye disease, you can manage it, you can prevent it with a topical cromolyn. Okay, so some clinical strategies. This is something that a recent journal came out with that you can use if you're dealing with children. So these are factors that are associated with a non-diagnosis of conjunctivitis. So being older than 6 is associated with not conjunctivitis. It's disassociated with conjunctivitis. If the patient is older than 6, they're less likely to have conjunctivitis than if they were younger than 6. If they present in those late spring, summer, early fall months, April through November, they're less likely to have conjunctivitis than if they presented between November and April. If they do not have purulent discharge, they're less likely to have conjunctivitis than if they were to have watery or no discharge. And if they don't have that glued eye problem in the morning or after they wake up, they're less likely to have conjunctivitis than if they did. So if they have 3 of these factors in the affirmative, then it's a 76.4% chance that it's not conjunctivitis. If 4 factors are present, it's 92.3%. So don't memorize those percentages. Just know these sort of statistics, these associations that are associated, or in this case, associated with the non-diagnosis of conjunctivitis. And this is what I like to use for differentiating red eye, determining what to do. So this is a little algorithm that I like to use. So if you have a patient come in with a red eye, the most important question to ask them is, how's the pain? If they rate it at a 10 out of 10 or an 8 out of 10, then you're going to be referring them to ophthalmology because you're concerned of uveitis or glaucoma, which is going to need to be treated by an ophthalmologist on an emergent basis. If there is not severe pain, if it's just discomfort, then the next question you ask them is there blurred vision? Remember, with conjunctivitis, you should not have blurred vision. So if they do have blurred vision, the next question you ask them is, is it made worse by light, or is light uncomfortable for you? And if they say yes, you're going to be referring them for ophthalmology, but not because of uveitis or glaucoma, because in this case we're more concerned about something like corneal abrasion. So if they do not have severe pain, no blurred vision, then you want to know, is there a discharge? If there's a discharge, it's probably conjunctivitis. And if it's purulent discharge, you generally know from the outset that it's probably bacterial conjunctivitis. In that case, you want to consider their sexual history because it could be either your gonorrheal or chlamydial conjunctivitis. But usually the chlamydial conjunctivitis is watery discharge. If there is watery discharge, you want to know if there's severe itchiness. Remember, severe itchiness is associated with allergic conjunctivitis. So if there is severe itchiness, probably allergic. If there's not severe itchiness, it's probably viral. And from the onset, some of those viral causes of conjunctivitis, you can usually tell right away. If there's any kind of rash around the eye, it's probably a herpes or varicella problem. If there is no discharge, then you can just ask them right away, is there severe itchiness? If yes, probably allergic conjunctivitis. If no, then we're really probably don't have a diagnosis of conjunctivitis here. Probably something like dry eye disease or blepharitis. So what's most important out of this to remember is that conjunctivitis is not associated with severe pain. If it's severe pain, you got to be thinking other things like uveitis or glaucoma. And then you should not have a change in your visual acuity. If there's a change in your visual acuity, it's probably something more problematic. So conjunctivitis is red eye, but with no severe pain and no blurred vision. And then with the discharge, purulent discharge is associated with bacterial conjunctivitis. And as far as treatments, typically you can treat any of these with just supportive care. However, bacterial conjunctivitis, if it is gonococcal or chlamydial, you'll need to treat that appropriately. With allergic conjunctivitis, you can use topical NSAIDs. You can use topical antihistamines. That will usually clear it up. If that doesn't work, you can move on to corticosteroids, topical corticosteroids, or something even more significant, but we try not to use that. We try to keep it to corticosteroids. So if you have any questions, you can feel free to comment below.